Joseph, a 42-year-old man, comes to the clinic because he's been waking up many times at night, which makes him very sleepy during the day. His partner also complains that Joseph has always snored, but recently it's louder than ever. On physical examination, he has a BMI of 35 kilograms per square meter and has a blood pressure of 140/90 millimeters of mercury. You decide to conduct a sleep study, which reveals a very low partial pressure of oxygen. Later, a 35-year-old woman called Robin also comes to the clinic. She tells you that lately she's been experiencing shortness of breath and fatigue. Robin is quite worried and mentions that she has a congenital heart defect. On physical examination, she has a mean pulmonary arterial pressure of 28 millimeters of mercury. You decide to perform an electrocardiogram, or ECG test, and a chest X-ray, which show that Robin has right ventricular hypertrophy. Based on the presentation, both cases seem to have some respiratory disease associated with some cardiovascular issues. Now, for your exams, some important conditions include sleep apnea, obesity hypoventilation syndrome, and pulmonary hypertension. So let's begin with sleep apnea. This is when a person, during their sleep, experiences recurrent and intermittent episodes in which they stop breathing for more than 10 seconds. In addition, since fresh air is not getting into the lungs, individuals with sleep apnea will have nocturnal hypoxia. This puts the body under stress, which in turn responds by releasing epinephrine. Now, the recurrent epinephrine surges have several effects. Firstly, this wakes up the person so that they can breathe again. This causes disrupted sleep, which in turn leads to somnolence or sleepiness during the day or while awake. Secondly, the body tries to compensate for hypoxia by increasing the amount of red blood cells, or erythrocytes, available to carry the oxygen in blood to our tissues. To do so, our kidneys produce a hormone called erythropoietin, or EPO, which stimulates the bone marrow to produce more red blood cells, and this process is known as erythropoiesis. The problem with sleep apnea, though, is that even if we increase the number of red blood cells, the amount of oxygen that's entering the body is not enough, so there's still hypoxia. Third, having high epinephrine levels can cause vasoconstriction, increasing the vascular resistance. Over time, this can result in vascular remodeling, which can lead to development of both pulmonary and systemic hypertension. Pulmonary hypertension is when the blood pressure in the lung arteries is increased, while systemic hypertension involves the arteries of the rest of the body. Over time, this can put too much strain on the heart and ultimately cause abnormal heart rhythms like atrial fibrillation or atrial flutter, heart failure, and even sudden death. Diagnosis of sleep apnea involves a sleep study, also known as a polysomnography, which counts the number of apnea episodes and monitors several parameters like heart rhythm and oxygen saturation. Another important diagnostic value is partial pressure of oxygen in the arteries, since it helps us understand if the tissues are receiving adequate oxygen supply. This value can be easily and indirectly obtained with a pulse oximeter, or directly obtained via blood gas sampling. For your exams, remember that people with sleep apnea have low oxygen saturation levels, and thus low partial arterial pressure of oxygen during sleep, but bear in mind that this partial pressure is typically normal when they're awake. Now, when the cause of sleep apnea originates in the central nervous system, it's called central sleep apnea. Most often, though, sleep apnea is caused by an obstruction of airflow in the airways, which is known as obstructive sleep apnea. And when a person experiences both obstructive and central sleep apnea, it's called complex or mixed sleep apnea. Okay, let's start with central sleep apnea, or CSA for short. Central sleep apnea is caused by an imbalance in the respiratory center of the brain, so during sleep it fails to activate the muscles that control breathing. The main causes of central sleep apnea include central nervous system injury involving the respiratory center, as well as central nervous system toxicity, often due to use of opioid medications. Another major risk factor for central sleep apnea is congestive heart failure. What's important for your exams is that congestive heart failure leads to increased chemosensitivity, which is how the body senses and responds to changes in the partial pressures of oxygen and carbon dioxide. So when there's an apnea episode, oxygen levels decrease while carbon dioxide levels rise. Now, keep in mind that carbon dioxide is the main stimulus for the respiratory center, so when there are high levels of carbon dioxide, the respiratory center responds by increasing our respiratory rate. Now, when there's increased chemosensitivity, the increased CO2 triggers an exaggerated response in the form of hyperventilation and ends up decreasing the carbon dioxide too much. So now the CO2 level is too low, and this ultimately causes depression of the respiratory center and thus another apnea episode. As a result, there's a vicious cycle that leads to central sleep apnea. Now, when central sleep apnea is associated with congestive heart failure, it often manifests as an abnormal breathing pattern called Cheyne-Stokes respiration, also known as cyclic respiration. This is a periodic breathing characterized by oscillation between periods of apnea alternated with deep breaths or hyperpnea. So, for your exams, remember that the three main things you need to know all start with a C for central sleep apnea. The first is central nervous system injury or toxicity, the second C is congestive heart failure, and the third C is for Cheyne-Stokes respiration. Treatment of central sleep apnea mainly involves positive airway pressure therapy, as well as taking care of the underlying cause. And then we have obstructive sleep apnea, or OSA for short. As the name suggests, it is caused by a narrowing or obstruction of the airways. Now, normally the airway muscles relax while sleeping. In healthy people, though, the airway muscle tone is strong enough to counteract factors that would cause the airway to collapse, such as gravity while lying down and the negative pressure in the airway during inspiration. In obstructive sleep apnea, the airway muscle tone is not strong enough to counteract these factors, and so the airway collapses. In adults, the most common cause is an excess of parapharyngeal tissue, which basically means that there's excess fat in the neck region. That's why obstructive sleep apnea is most common in obese individuals, so those with a BMI over 30 kilograms per square meter. On a test question, the most important clue suggesting obstructive sleep apnea is loud snoring in an obese individual, like they're trying to gasp for air until they wake up. This leads to disrupted sleep, which in turn causes excessive sleepiness during the day or while awake. Sometimes, though, obstructive sleep apnea may affect children. In this case, the most common cause is adenotonsillar hypertrophy, meaning an enlargement of the pharyngeal and palatine tonsils. Treatment of obstructive sleep apnea involves continuous positive airway pressure, or CPAP therapy, which delivers a steady stream of pressure in order to keep the airway open. In addition, weight loss is highly recommended for overweight people. Finally, one last option is surgery to remove the excess parapharyngeal tissue. Now, another important respiratory disease that's very often related to obstructive sleep apnea is obesity hypoventilation syndrome, or OHS for short. Obesity hypoventilation syndrome is also named Pickwickian syndrome after Charles Dickens' novel The Pickwick Papers, in which there is an overweight character who's constantly falling asleep at any time of the day. As the name suggests, obesity hypoventilation syndrome only affects obese individuals. That's because the excess weight can restrict the movement of the diaphragm and chest wall, which impairs lung expansion. As a result, affected individuals develop hypoventilation, meaning slow or shallow breathing. In most cases, obesity hypoventilation syndrome also causes obstructive sleep apnea and hypoventilation during sleep, but bear in mind that these individuals also experience hypoventilation while awake. And that's a high-yield fact. Because of that, diagnosis of obesity hypoventilation syndrome includes an increased partial pressure of carbon dioxide while awake, and while sleeping, they'll also have a decreased partial pressure of oxygen. Treatment is mainly focused on weight loss, and some cases can also get positive airway pressure during sleep. Okay, let's switch gears to pulmonary hypertension, or PH for short, which is defined as a mean pulmonary pressure at rest that's greater than 25 millimeters of mercury. And this often results in 4 hallmark pathological changes to the pulmonary arteries. Now, to remember these 4 pathological changes, think of the mnemonic "ants in my pants." The first change is arteriosclerosis, in which the arterial walls become thicker, harder, and lose elasticity. Another change is intimal fibrosis, which is similar to arteriosclerosis, but only involves the tunica intima, which is the innermost layer of the arteries. Then there's medial hypertrophy, meaning a thickening of the tunica media, which is the middle layer of the arteries. Now, these three changes can lead to a narrowing or even closing of the pulmonary arteries, which compensate by forming new networks of vascular channels between the arterial branches. These channels are known as plexiform lesions and are the fourth pathological change. Over time, pulmonary hypertension can progress to severe respiratory distress, and individuals may present cyanosis, or bluish skin discoloration due to poor blood oxygenation. In addition, since the lung arteries are narrowed, the pressure inside increases. And since the afterload of the right ventricle is proportional to the pulmonary pressure, it becomes harder for the heart to pump blood, so it backs up, leading to an overload in the right heart. In response, the heart muscle will try to compensate by progressively remodeling its shape and size and becoming thicker. This is called right ventricular hypertrophy, or RVH. Ultimately, the heart isn't able to compensate anymore, which leads to cor pulmonale, meaning right-sided heart failure that's caused by a lung condition. If not treated, decompensated cor pulmonale is fatal. Now, pulmonary hypertension can be classified based on the underlying cause into 5 groups. Group 1 is pulmonary arterial hypertension, or PAH for short. Now, pulmonary arterial hypertension refers specifically to pulmonary hypertension that's caused by a progressive stiffening and constriction or narrowing of the arteries in the lungs. This is often associated with endothelial dysfunction, meaning that the endothelial cells start producing more vasoconstrictors, such as endothelin, but less vasodilators like nitric oxide and prostacyclins. Now, the reason why this happens is most often idiopathic, meaning its cause is unknown. However, there are some well-understood causes that you must know for your exams. These causes include congenital heart disease associated with left-to-right shunts, which is when an anatomical defect of the heart septum causes blood to leak from the left side into the right side, as well as portal hypertension, which refers to increased pressure in the portal vein that drains blood from the gastrointestinal tract into the liver. Other causes include connective tissue diseases, such as lupus or scleroderma, as well as some infectious diseases like HIV infection or schistosomiasis, which is caused by the parasitic flatworm schistosoma. Pulmonary arterial hypertension can also be caused by some abuse drugs like cocaine and amphetamines. In addition, some cases of pulmonary arterial hypertension can be inherited. Now, heritable pulmonary arterial hypertension is caused by an inactivating mutation in the BMPR2 gene. Normally, the BMPR2 gene codes for a protein that inhibits the proliferation of smooth muscle cells, and this is particularly important in blood vessels. What's important for you to know is that the inactivation of BMPR2 leads to medial hypertrophy of the lung arteries, and this generally has a poor prognosis. Alright. Now let's go back to the causes of pulmonary hypertension. Group 2 is left-sided heart disease, which can be due to congenital heart defects, systolic or diastolic dysfunctions, or a valvular disease. Remember that the left side of the heart receives oxygenated blood coming from the lungs and then pumps this blood to the rest of the body. So when the heart's ability to pump blood is compromised, the backflow of blood leads to increased pressure in the pulmonary circulation. Group 3 is pulmonary hypertension caused by chronic lung diseases like chronic obstructive pulmonary disease, or COPD, in which the lung parenchyma is destroyed, as well as interstitial lung disease, in which there's inflammation and fibrosis of the lungs. Group 3 also includes any condition that causes hypoxia, such as living at high altitudes or having sleep apnea. To compensate for the hypoxia, the lungs try to divert blood into lung segments with better oxygenation by constricting the small pulmonary arteries of poorly oxygenated alveoli. This mechanism is known as hypoxic pulmonary vasoconstriction. Group 4 is for chronic thromboembolic pulmonary hypertension, which is when there's recurrent or chronic formation of thrombi or blood clots that may block or damage the pulmonary arteries. As a result, blood cannot flow properly through the affected arteries, ultimately causing an increased pressure in the pulmonary arterial tree. Chronic thromboembolic pulmonary hypertension can be associated with clotting disorders, chronic inflammatory diseases, or systemic diseases like cancer. The fifth and last group is multifactorial, meaning multiple causes, and mainly refers to less common causes of pulmonary hypertension that don't fit into the other groups. Multifactorial causes include metabolic disorders like thyroid disorders, blood disorders like anemia, systemic disorders like sarcoidosis, and tumors that compress the pulmonary vessels. Okay, we're near the end. Diagnosis of pulmonary hypertension is usually made with right heart catheterization, where a catheter is inserted through the right heart to measure the pulmonary pressure. Pulmonary hypertension is diagnosed when the mean arterial pressure is greater than or equal to 25 millimeters of mercury. Follow-up tests can be done to identify the underlying cause and can include an ECG and imaging, among others. Finally, treatment of pulmonary hypertension generally involves giving supplemental oxygen, and further treatment options will depend on the underlying cause. So for instance, if the cause is pulmonary arterial hypertension, medications like endothelin receptor antagonists and prostacyclins can be given. If the cause is left heart disease, treatment can involve medications aimed at boosting the heart's performance or lowering the blood pressure. And if the cause is chronic thromboembolic pulmonary hypertension, treatment can involve long-term anticoagulants as well as surgery to remove the thrombi when possible. Alright, as a quick recap, sleep apnea is when an individual intermittently stops breathing for at least 10 seconds during sleep, and it's typically associated with snoring, disruptive sleep, and daytime sleepiness, as well as nocturnal hypoxia that over time can lead to hypertension, arrhythmias, and sudden death. Sleep apnea could be central due to an imbalance of the respiratory center in the brain during sleep and is associated with central nervous system toxicity or injury, congestive heart failure, and Cheyne-Stokes respiration, whereas obstructive sleep apnea most often occurs in obese individuals and is associated with airway obstruction and loud snoring. A potentially related disease is obesity hypoventilation syndrome, also known as Pickwickian syndrome, which affects obese individuals presenting shallow or slow breathing and increased partial pressure of carbon dioxide both during sleep and while awake. Treatment of sleep apnea can include weight loss, positive airway pressure, or surgery. Lastly, pulmonary hypertension is characterized by a mean pulmonary pressure at rest that's greater than 25 millimeters of mercury. Its 4 hallmark pathological changes include arteriosclerosis, intimal fibrosis, medial hypertrophy, and plexiform lesions. Eventually, there's a severe respiratory distress leading to cyanosis, right ventricular hypertrophy, decompensated cor pulmonale, and death. The causes of pulmonary hypertension are classified into 5 groups, including pulmonary arterial hypertension, left heart disease, chronic lung diseases or hypoxia, chronic thromboembolic pulmonary hypertension, and multifactorial causes. Okay, back to our cases. Joseph is a 42-year-old man who experiences sleeping problems associated with loud snoring and sleepiness during the day. This is already pretty suggestive of obstructive sleep apnea. This is further supported by the fact that Joseph is obese and has systemic hypertension. The final clue is given by the sleep study, which reveals nocturnal hypoxia. And since Joseph has none of the 3 main C's, you can rule out central sleep apnea. Next, Robin is a 35-year-old woman complaining of shortness of breath and fatigue that may be related to her congenital heart disease. This, combined with her high mean pulmonary arterial pressure, should make you think of Group 2, or left-sided heart disease causing pulmonary hypertension. In addition, Robin's ECG and chest X-ray show right ventricular hypertrophy, which is a common compensation mechanism to pulmonary hypertension. If Robin doesn't get treatment, she might eventually develop cor pulmonale.
Hannah is a 42-year-old woman who came to the emergency department due to pain in her right calf. She reports flying from Japan back to the United States only 2 days ago. She denies fever, chills, or a history of trauma to the leg. She reports a 25-pack a year smoking history for 20 years, and she takes oral contraceptive pills. On physical examination, she's stable, and her BMI is 32. Her right leg is shown in this image. On laboratory investigation, her D-dimer levels are elevated. Deep vein thrombosis, or DVT, and pulmonary embolism, or PE, are a spectrum of clinical manifestations that result from venous thromboembolism. The pathogenesis and risk factors of both DVT and PE center around Virchow's triad, that is, stasis of blood flow, hypercoagulability, and endothelial injury. Board exams like to test your ability to identify a PE by using scenarios that promote venous stasis, such as paralysis after a stroke, the post-operative period, as well as long drives or flights. People with varicose veins are also at risk of DVT because incompetent venous valves prevent proper venous outflow, causing stasis. An interesting risk factor is pregnancy, where the enlarged uterus may compress the iliac veins, causing stasis of venous outflow. Another similar cause is May-Thurner syndrome, where the left iliac vein gets sandwiched between the right iliac artery anteriorly and the lumbar vertebra posteriorly, which also lead to venous stasis. Now, the coagulation system is normally balancing clot formation and clot lysis. Hypercoagulability occurs when the scale is tipped toward clot formation. This may be genetic, such as factor V Leiden, or antithrombin 3 deficiency, or it may be acquired, like when there's high estrogen during pregnancy, or when using estrogen-containing oral contraceptive pills. Also, nephrotic syndrome causes loss of antithrombin 3 in the urine, resulting in hypercoagulability. This is especially prominent in membranous glomerular nephropathy. Other acquired causes of hypercoagulability include malignancies, sepsis, and autoimmune diseases like lupus or antiphospholipid syndrome. Finally, endothelial damage, like when there's a trauma, can expose the underlying collagen, which initiates the coagulation cascade. All right. Now, DVTs typically affect the deep veins of the lower extremity, such as the popliteal, iliac, and femoral veins. The popliteal veins of the calf are most commonly affected. However, it's important to remember that the more proximal iliofemoral DVTs that commonly embolize and cause PE. DVTs present with unilateral, painful swelling and redness of the affected extremity. However, it's important to know that there are other differential diagnoses, like cellulitis or a popliteal Baker cyst, that can present similarly. So, when it comes to diagnosis, the best choice on an exam is a compression ultrasound with Doppler. Normally, veins are easily compressible using the ultrasound probe, but when there's a clot, the affected vein becomes incompressible. Doppler is beneficial because they can also look at blood flow. Next, D-dimer is a fibrinogen degradation product that may be measured if DVT is suspected. A negative test may be helpful to rule out DVT, but a positive test does not necessarily mean there is DVT. So, D-dimer has a high sensitivity but a low specificity for DVT. Now, PE most commonly occurs when a DVT breaks off and travels to the pulmonary artery or one of its branches. When the pulmonary artery is obstructed, perfusion to the supplied segment of the lung is limited. However, there's nothing wrong with ventilation. So now we have a ventilation-perfusion mismatch, or a VQ mismatch, where there's plenty of oxygen in the alveoli, but there's not enough RBCs to pick it up. This decreases the oxygen saturation in the blood, or hypoxemia. In response to hypoxemia, the pulmonary blood vessels vasoconstrict, which shunts blood from the poorly perfused segments to the well-perfused segments. This process is called intrapulmonary shunting. Additionally, peripheral chemoreceptors pick up on hypoxemia and send signals to the brain to increase ventilation in an attempt to compensate. Hyperventilation causes the individual to blow off lots of carbon dioxide, resulting in respiratory alkalosis. Now, most of the time, when a clot occludes a blood vessel, the distal organ tissue dies and becomes infarcted. The lung is an exception because it receives a dual blood supply from both the pulmonary artery and bronchial arteries, which are branches of the aorta. Okay, so large emboli that occlude the pulmonary trunk place tremendous amounts of sudden pressure on the right heart. So it's important for you to remember that this can result in acute right heart failure and a form of shock called obstructive shock. Obstruction of the right ventricular outflow tract means the left heart isn't getting enough blood, which decreases left ventricular filling and ultimately stroke volume. Okay, now let's tie the pathophysiology to the clinical presentation. Hypoxemia and hyperventilation means individuals with PE present with sudden onset shortness of breath and tachypnea. Additionally, because PEs limit left ventricular stroke volume, the heart tries to compensate by increasing the heart rate, so tachycardia. PE can also present with pleuritic chest pain that is worse on inspiration. Additionally, hemorrhagic infarction may cause the individual to develop hemoptysis. A combination of hypotension, a distended jugular vein, and clear lung sounds often clue towards obstructive shock. Now, approximately 20% of the population have a patent foramen ovale. This means that the clot can travel from the right atrium to the left atrium to the left ventricle and into the arterial circulation. So a possible presentation to consider is actually an embolic stroke. The ECG in PE most commonly shows sinus tachycardia, but sometimes a unique pattern called the S1Q3T3 pattern may appear. This means an S wave in lead 1, a Q wave in lead 3, and an inverted T wave, also in lead 3. This pattern is not specific for PE. Rather, it's essentially a distress signal from the right heart, signifying right heart strain. The best diagnostic test is a CT pulmonary angiogram, which shows a filling defect in the pulmonary artery or its branches. For your exams, it's also important to remember that microscopic examination of the thrombus will show the characteristic lines of Zahn. These are alternating layers of pink platelets and fibrin as well as layers of red RBCs. These lines are only found in thrombi formed before death, so they help distinguish a premortem from a postmortem thrombus. Okay, when using the term PE, this usually refers to pulmonary thromboembolism. However, there are some rare causes of PE that might also show up on a test. Fat emboli occur when there's long bone fractures, orthopedic procedures, and liposuction. In these scenarios, fat globules are released into the circulation. They are exposed to lipoprotein lipase, which degrades them into free fatty acids like oleic acid. These free fatty acids damage the endothelium of various organs. When it's the endothelium of the lungs, acute respiratory distress syndrome, a form of pulmonary edema occurs. When it's the endothelium of the skin, a petechial rash appears. And when it's the endothelium of the brain capillaries, neurological deficit occurs. This culminates into a triad of ARDS, petechia, and diffuse neurological impairment. On microscopy, fat can be seen intravascularly and stains black with osmium tetroxide. Then there's amniotic fluid emboli. Risk factors include being in the peripartum period, maternal age above 30, and uterine trauma. These all increase the risk of amniotic membrane rupture. Amniotic fluid contains amino acid metabolites that are considered foreign to mom's body. So this triggers an immune reaction that looks like anaphylaxis or an anaphylactoid reaction. This causes vasospasm in the pulmonary arteries, leading to pulmonary hypertension and left heart failure. Amniotic fluid also contains tissue factor, which triggers the coagulation cascade, resulting in disseminated intravascular coagulation, or DIC. On microscopy, fetal squamous cells and mucin are seen in mom's pulmonary arteries. Air emboli are up next. And for these to happen, there must be direct communication between the atmosphere and a blood vessel lumen, as well as a pressure gradient favoring air entry. Risk factors include neurosurgical procedures, laparoscopic surgery, and any blunt or penetrating trauma that exposes blood vessels to air. Once air enters smaller vessels, it could form bubbles that end up blocking blood flow. A specific form of air embolism that occurs in divers is decompression sickness, or caisson disease. To put it simply, when a diver descends, nitrogen begins to accumulate in lipid-rich tissues. If they ascend rapidly, large amounts of nitrogen quickly transform into its gas form, forming bubbles that obstruct the circulation. This is why it's advised to ascend slowly, to allow nitrogen to slowly get out of the circulation and to the lungs. Finally, septic emboli can occur in people with endocarditis. These are little clumps of pathogens that detach from the surface of the tricuspid valve and travel through the pulmonary arteries and into the lungs. For your exams, remember that the major risk factor for tricuspid valve endocarditis is IV drug use. All right, as a quick recap, the two main forms of venous thromboembolism are DVT and PE. The pathogenesis and risk factors for both revolve around Virchow's triad, which includes stasis, hypercoagulability, and endothelial injury. DVT most commonly affects the calf, but it's the proximal venous DVTs that usually embolize to cause PE. DVT presents with a unilateral limb swelling and erythema, and diagnosis is confirmed with a compression ultrasound. PE causes a VQ mismatch, resulting in hypoxemia and hyperventilation, which causes a respiratory alkalosis. Individuals present with acute, sudden onset shortness of breath, pleuritic chest pain, hemoptysis, and sometimes obstructive shock. Diagnosis is confirmed with a CT pulmonary angiogram. It's also important to consider rarer causes of PE, such as fat, air, septic, and amniotic fluid emboli. Okay, back to our case. Hannah is presenting with DVT. Her risk factors include a prolonged period of immobilization from her long flight, obesity, smoking, and the use of oral contraceptive pills, which all increase coagulability. Her D-dimer was elevated, suggesting the possibility of DVT. A compression ultrasound was performed and confirmed DVT. She is now doing well on anticoagulation therapy.
Two people came into the clinic one day. First is a 65-year-old named Alex, who presents with a 2-month history of dry, persistent cough and weight loss of around 7 pounds without dieting. He also says he coughs up blood sometimes, but denies fever, dyspnea, sore throat, rhinorrhea, or any chest pain. Alex has a history of asthma and hypertension, and smoked 1 pack of cigarettes daily for 45 years. On examination, his breath sounds are diminished at the right lung base. The other individual is Clara, who's an 80-year-old retiree. Before her retirement, Clara was a construction site supervisor. She complains of increasing shortness of breath, which started 10 months ago, and new onset of myalgia located on the right side of her chest. Physical examination reveals decreased breath sounds in the right lung base along with dullness to percussion. Chest x-rays were ordered for both people. In Alex's case, it showed a single coin-like lesion on the right lung base. Clara's scan showed pleural effusion, irregular pleural thickening, and 2 ivory-white calcified pleural plaques at the base of her right lung. Both people have cancer involving the lung. But first, let's do a bit of physiology. Lining the airways are several types of epithelial cells that serve multiple functions. These include ciliated cells that have hair-like projections called cilia that work to sweep foreign particles and pathogens back to the throat to be swallowed. Another type, called goblet cells, secrete mucin to moisten the airways and trap foreign pathogens. There are also basal cells that are thought to be able to differentiate into other cells in the epithelium, club cells that act to protect the bronchiolar epithelium, and neuroendocrine cells that secrete hormones into the blood. On the outside, the lungs are covered by the mesothelium, which consists of the parietal pleura and the visceral pleura. Between them, there's the pleural space, where the fluid produced by the epithelial cells is released, which acts as a lubricant to allow the layers to slide effortlessly against each other during respiratory movements. Now let's begin with lung cancer. The two most common types are small cell lung cancer and non-small cell cancer, both sharing common pathophysiology. Cells of the lungs can undergo mutations that cause them to divide uncontrollably and replace the normal healthy lung tissue. Eventually, these cells will form a tumor. To supply it, new blood vessels also develop, and this is called angiogenesis. Sometimes the tumor can metastasize and spread via blood vessels, or lymphatics, and establish secondary sites throughout the body. Particularly at risk for lung cancer metastasis are the mediastinum and hilar lymph nodes because of their proximity to the lungs. So remember this as it's very high yield. Other common sites include the liver, adrenal glands, bones, and brain. There are many risk factors for lung cancer. Tobacco smoking is the most important one, which accounts for more than 90% of cases of lung cancer. This usually comes in the form of cigarettes, but also includes cigars, pipes, and hookah. There's a dose-dependent linear relationship between lung cancer risk and pack years, which is the number of cigarette packs per day times the number of years of smoking. Secondhand smoke also increases the risk of lung cancer. The second leading risk factor for lung cancer is exposure to radon, a colorless, odorless gas which is a natural breakdown product of uranium found in the soil, so it sometimes accumulates in basements. Other environmental factors include asbestos, a mineral made of long, fibrous crystals that was commonly used for construction until the 1980s in the US. The most common type of cancer caused by asbestos is adenocarcinoma. Next, there's air pollution and ionizing radiation from medical imaging with chest x-rays and CT scans, or during radiation therapy. The symptoms of lung cancer vary based on the size and location of the tumor, whether or not it has spread to other organs, and whether or not it secretes hormones. Initially, individuals may be completely asymptomatic. Over time, in response to the cancer, the body mounts an immune response to fight it off. This results in the release of inflammatory chemokines like TNF-alpha, IL-1 beta, and IL-6. The chemokines cause unintentional weight loss, fever, malaise, and night sweat. If the primary tumor physically obstructs the airway and presses on surrounding tissue, it can cause coughing, shortness of breath, and wheezing. Since the obstruction can decrease the clearance of mucus, it also increases the risk of developing pneumonia. Sometimes, the tumor obstructs the bronchus and prevents the ventilation for a lobe, or even an entire lung. This will cause obstruction atelectasis, where the lung could collapse. Compression of nearby nerves can cause pain, and compression of specific nerves, like the recurrent laryngeal nerve and phrenic nerves, can cause hoarseness or difficulty breathing, respectively. Another high-yield fact is that compression of nearby vessels, like the superior vena cava, can prevent blood from draining from the head, leading to facial swelling or puffiness. If the swelling occurs in the epiglottis, it could cause difficulty breathing, and if there's swelling in the brain, it could cause headaches and altered mental status, both of which can be medical emergencies. Finally, if tumor necrosis occurs, or if cancer cells invade a blood vessel, individuals can experience hemoptysis. A high-yield fact is that sometimes a tumor can arise in the superior sulcus, which is the space formed by the subclavian vessels, and these are called Pancoast tumors. These are most often non-small cell carcinomas, and can compress the blood vessels and nerves located in the region. Some important symptoms to remember include arm muscle weakness and paresthesia due to compression of the brachial plexus, and pain that irradiates to the scapula and arm on the affected side. Since Pancoast tumors near the thoracic inlet can compress cervical sympathetic ganglia, it can lead to Horner syndrome, which causes constricted pupil, drooping upper eyelid, which is called ptosis, and anhidrosis, or the inability to sweat. Okay, now let's discuss small cell carcinomas, which account for a small percentage of lung cancer. They are associated with amplification of the MYC oncogene and originate from small, ovoidal neuroendocrine cells. These tumors usually develop centrally in the lung near a main bronchus. They also grow the fastest and tend to rapidly metastasize to other organs when compared to non-small cell lung cancers. Small cell carcinomas can sometimes secrete hormones, and that can lead to what is called a paraneoplastic syndrome. One example is that they can release adrenocorticotropic hormone, or ACTH. This leads to bilateral adrenal enlargement and an increase in cortisol production. The result is Cushing's syndrome. And some symptoms include elevated blood glucose, high blood pressure, skin hyperpigmentation, easy bruising, osteoporosis, frequent infections from a weakened immune system, and weight gain. Next, these tumors can also release antidiuretic hormone. This is called syndrome of inappropriate antidiuretic hormone, or SIADH, which increases water reabsorption in the renal collecting ducts, leading to high blood pressure, hyponatremia, edema, and concentrated urine. Finally, small cell carcinoma can trigger the production of autoantibodies against neurons. If cerebellar neurons are affected, it leads to symptoms like ataxia and nystagmus. If neurons in the cerebrum are affected, then it can lead to symptoms like dementia and seizures. There's also Lambert-Eaton syndrome, where the autoantibodies target voltage-gated calcium channels on the presynaptic membrane at the neuromuscular junction. This condition results in muscle weakness, especially in the proximal muscles of the legs, but it also causes double vision, drooping of the eyelids, and difficulty swallowing. The other type is non-small cell carcinomas. They account for most lung cancers and can be further subdivided into 4 categories. Adenocarcinomas, which frequently form glandular structures or have the ability to generate mucin. They are associated with mutations of the KRAS, EGFR, and ALK genes. In squamous cell carcinomas, the cells are square-shaped and produce keratin. Carcinoid tumors arise from mature neuroendocrine cells, and there are large cell carcinomas, where the cancer cells are poorly differentiated and lack the characteristics of the other types. Now, these carcinomas are also more of a mixed bag in terms of where they're located. First, adenocarcinomas tend to develop peripherally, in a bronchial or alveolar wall, and they're associated with non-smokers. However, it is worth mentioning that even though adenocarcinomas are the most frequent type of lung cancer in non-smokers, the majority of adenocarcinomas occur in smokers. Adenocarcinomas are also associated with hypertrophic osteoarthropathy, or clubbing of the digits. This is due to abnormal proliferation of skin and periosteal tissues involving the extremities. A rare subtype of adenocarcinoma is called bronchoalveolar carcinoma, and it originates from the columnar mucin-secreting alveolar cells located in the periphery of the lung. Its typical presentation includes dyspnea and a cough that produces a large amount of golden brown sputum. This type of adenocarcinoma usually has a better prognosis. Second, squamous cell carcinomas tend to be centrally located, and it has the highest association with smoking. A classic paraneoplastic syndrome associated with this carcinoma is that they release parathyroid hormone-related protein. This protein acts like parathyroid hormone and increases bone resorption, which increases calcium levels in the blood, but causes bones to become brittle. Finally, large cell carcinomas and bronchial carcinoid tumors can be found throughout the lungs, but are more common in the periphery. A high-yield fact for carcinoid tumors is that they can secrete serotonin, which leads to increased peristalsis and diarrhea, facial flushing, and wheezing due to bronchoconstriction. Okay, now let's switch gears and look at mesothelioma, a cancer of the lung lining. The most common risk factor is asbestos exposure. But remember that asbestos causes more cases of bronchogenic carcinomas like adenocarcinoma and small cell carcinoma. Once the small fibrous asbestos crystals are inhaled, they enter cells in the lungs, or mesothelium, and get tangled up with the cell's chromosomes and damage the DNA. This can lead to mutations that cause the cells to replicate out of control. In the mesothelium, this leads to the growth of small nodules that could form mesothelial plaques. The plaques can grow rapidly and start to cover the visceral and parietal pleura. Interestingly, these growths start to express a lot of calretinin, a calcium-binding protein, involved in regulating calcium levels within the cell. Mesothelioma can cause the same symptoms as lung cancer, but it can also cause pneumothorax and hemorrhagic pleural effusion. Now, for diagnosing lung cancer, chest X-ray is a common first step. In most types of lung cancer, X-rays usually show a parenchymal lesion like a poorly defined nodule, called a coin lesion. For the bronchoalveolar subtype, a high-yield clue is that there's usually hazy infiltrates and thickening of the alveolar walls. For squamous cell carcinoma, cavitary lesions are common. On chest CT, the lesion appears as a non-calcified nodule, and CT will also help to stage the tumor, better define the tumor location, detect mediastinal or hilar lymph node metastasis, and look for evidence of local invasion. Okay, so diagnosing mesothelioma can also begin with a chest X-ray followed by a CT scan, with key findings being pleural thickening, pleural effusion, or pneumothorax. A key finding that's high yield is the presence of ivory white calcified supradiaphragmatic and pleural plaques, which are pathognomonic of asbestosis, a condition that usually precedes mesothelioma. Once a suspicious lesion is found, a biopsy is needed to see if the tumor is malignant and to identify the type of carcinoma based on histological features. An important one for small cell carcinoma is the presence of Kolchitsky cells, which are small, dark blue cells. A high-yield fact is that they are positive for enolase, neurofilaments, and neuroendocrine markers like synaptophysin and chromogranin. A biopsy sample for adenocarcinomas will be positive for mucin. Squamous cell carcinomas will have keratin pearls and intracellular bridges, and large cell carcinomas will have pleomorphic giant cells. In mesothelioma, the columnar cells that make up the tumor are joined by desmosomes and are studded with very long microvilli. A key finding is the presence of psammoma bodies, which are laminated, concentric nodules with calcification. Another clue is when immunostained with an antibody to calretinin, the cytoplasm and nuclei of the cancerous cells have a distinctive fried egg appearance. The treatment of small cell lung cancer can be tricky. Know that surgical removal is not indicated. This is because small cell carcinoma is highly aggressive and invasive, and most people already present with metastasis when diagnosed, making surgery pointless. The good news is that these tumors are, however, sensitive to chemotherapy and radiation therapy. In non-small cell lung cancer, surgery is typically recommended in most stages along with chemotherapy and radiotherapy. In addition, it's typical to remove nearby lymph nodes for biopsy in order to detect metastasis. Mesothelioma treatment also depends heavily on the stage of the disease, and it usually combines surgery, chemo, and radiation therapy. Alright, as a quick recap, lung cancer can be divided into small cell and non-small cell carcinoma. The tumors can cause airway obstruction and compression of nearby nerves and blood vessels like the superior vena cava. Some types are associated with specific paraneoplastic syndromes, and they can also induce an immune response which causes nonspecific symptoms like weight loss, fevers, and night sweats. Mesothelioma is often associated with asbestos, and it's a carcinoma that arises from the pleura. Some symptoms like dyspnea, cough, and hemoptysis are similar to lung cancer, but in addition, they can have symptoms similar to pneumothorax. Diagnosis begins with chest x-rays. In lung cancer, the most common finding is a poorly defined coin lesion. In mesothelioma, the most common signs include pleural thickening, pleural effusion, pneumothorax, and more importantly, calcified pleural plaques. Diagnosis is then confirmed by tumor biopsy. Usually, the tumors are treated with a combination of surgery, chemotherapy, immunotherapy, and radiation, depending on the situation. And finally, back to our cases. Alex has a 2-month history of a dry, persistent cough, hemoptysis, weight loss of about 7 pounds, and progressive tiredness. All of these can be signs of lung cancer. His long history of smoking and the absence of an infection are further clues. On examination, his breath sounds were diminished at the right lung base, but more importantly, his chest x-ray showed a coin lesion, which is our biggest clue. A CT and then a biopsy should be done to determine the stage and type of lung cancer. Clara, the 80-year-old retiree, has progressive shortness of breath and myalgia on the right side of her chest. Physical examination revealed decreased breath sounds in the right lung base associated with dullness to percussion. Her X-ray showed pleural effusion, irregular pleural thickening, and 2 pleural plaques. These findings suggest mesothelioma, and her previous occupation as a construction worker could have exposed her to asbestos, a known risk factor. A biopsy should be done for her to confirm the diagnosis.
During a night shift in the emergency department, you see George, a 21-year-old who complains of sharp, stabbing, left-sided chest pain and shortness of breath, both of which appeared suddenly while he was playing video games. He is a smoker and mentions his younger brother suffered a pneumothorax last year. On examination, the left side of his chest is slightly more expanded than the right side, and his breathing is very shallow. The affected side is also hyperresonant on percussion, and there's diminished breath sounds on auscultation. Then there's Anna, a 58-year-old with progressively worsening dyspnea, pleuritic chest pain, and fever. She has a history of diabetes and cirrhosis. On examination, her blood pressure and heart rate are both increased, and jugular venous pressure is elevated. Also, the base of her left lung field is dull to percussion, with decreased breath sounds. Her lower extremities have pitting edema up to the knee. X-rays were performed in both individuals. In George's case, it showed a retracted visceral pleural edge with a decrease in the left lung volume. In Anna, it showed left-sided costophrenic angle blurring. Now they both seem to present with conditions affecting the pleura, but to understand the pathophysiology, it's a good idea to review the anatomy and physiology first. Okay, so the pleura covers the lungs and consists of the parietal pleura, which is stuck to the chest wall, and the visceral pleura, which is stuck to the lungs. It extends all the way up to the clavicle and first rib, which is something that will help you understand why neck injuries can cause tension pneumothorax. Also know the inferior limit of the pleura is the 7th rib on the mid-clavicular line, the 10th rib on the mid-axillary line, and the 12th rib on the paravertebral line. Between the layers of the pleura is the pleural space, containing 10 to 20 milliliters of a lubricating fluid that helps reduce friction as the lungs expand and contract. There's also pressure within the pleural space, established by 2 main opposing forces. One is the muscle tension of the diaphragm and chest wall, which contract and expand the thoracic cavity outwards. The other is the elastic recoil of the lungs, which is the lungs' tendency to collapse inward. The two forces pulling in opposite directions creates a slight vacuum in the pleural space with the pressure of -5 centimeters of water relative to 0 centimeters of water in both the thoracic cavity and the lungs. The difference in pressure aids air exchange during inspiration and expiration to help the lungs keep their shape and not collapse. Okay, now let's look at the disorders that affect the pleura, starting with pneumothorax. A pneumothorax forms when the seal of the pleural space is punctured, letting air in and equalizing the pressure within the pleural space, lung, and chest cavity. As a result, the negative pleural pressure is lost, and the equilibrium between the two opposing forces disappears. The result is the affected lung simply pulls inwards and collapses. Now there are many types of pneumothorax. A primary spontaneous pneumothorax is one that develops in the absence of an underlying condition. And a clue to help you out is that these individuals tend to be thin, tall, young males who smoke. Another high-yield fact is that they often have a family history of pneumothorax. The cause is unknown, but they are believed to be due to apical subpleural blebs that rupture without warning. A secondary spontaneous pneumothorax is one that develops in someone with an underlying lung disease, where the lung or pleura structure is altered. One example you might encounter is emphysema, where bullae, which are air pockets, form on the surface of the lungs and then rupture. This creates a large hole in the visceral pleura, and air can go from the airway directly into the pleural space. There's also a traumatic pneumothorax, which is when trauma, like a gunshot or stab wound, or sometimes even iatrogenic causes, like lung biopsy or barotrauma due to mechanical ventilation, rips through the parietal pleura, allowing air to enter into the pleural space. Finally, there's tension pneumothorax, which can develop similarly to a spontaneous pneumothorax. One difference to keep in mind is that a flap of tissue near the leak can create a one-way valve for air to flow into the pleural space. In other words, air can enter but cannot leave. So air accumulates in the chest cavity and it pushes the organs in the mediastinum away from the affected side, which is called a mediastinal shift. This also causes compression of the organs, especially the venous system. This prevents blood from returning to the heart, which will reduce cardiac output and ultimately lead to obstructive shock. The symptoms of a spontaneous pneumothorax might only consist of shortness of breath and sudden unilateral pleuritic chest pain. This is a sharp, knife-like pain that worsens with deep inspiration, coughing, sneezing, or laughing due to irritation of the parietal pleura by the expanding lung. Clinical examination begins with vitals, which are usually normal except for rapid breathing or tachypnea. Now on inspection, because the chest wall springs outward a bit as the lung collapses, the chest wall on the affected side might appear bigger than the normal side. On chest palpation, chest expansion is uneven due to decreased chest wall movement of the affected side, and tactile fremitus is decreased. Tactile fremitus can be felt when the hand is placed on the chest wall. When a person says 99, the chest wall vibrates. If there's excess air in the pleural space, it absorbs some of this vibration energy, thus the vibrations weaken. Now when the chest is percussed, the extra air in the pleural space makes the resonant sound get louder. And this is something that can help you differentiate it from a hemothorax where the chest percussion is usually dull. Also, the extra air in the pleural space changes sound transmission in the chest, so on auscultation, normal breath sounds are diminished. Now in a tension pneumothorax, because air builds up, increasing the pressure inside the chest, the air starts compressing the organs in there. It's important to know that if it compresses the heart, It can lead to decreased cardiac output, low arterial blood pressure, distended neck veins, and tachycardia. Moreover, compression of the inferior vena cava decreases venous return, which leads to edema and even cardiac arrest. There's also deviation of the trachea towards the unaffected side. Finally, the normal lung can also be compressed, further limiting air exchange, resulting in cyanosis and respiratory failure. Typically, an X-ray or CT is needed for diagnosis, where you should look for a retracted visceral pleural edge, usually seen as a very thin, sharp white line, alongside a decreased lung volume due to the lung collapsing. The space beyond the visceral line is mostly black, because the space where the lung should be is filled with air. Commonly, in a tension pneumothorax, an X-ray or CT might show a mediastinal shift, which is seen as a tracheal deviation and displacement of chest structures away from the affected side. Now, treatment is not usually required in spontaneous pneumothorax, as they are usually small and the pleura will heal over time. In a larger pneumothorax that's causing severe symptoms, the air needs to be removed with a syringe or a chest tube connected to a one-way valve system. In a tension pneumothorax, the air needs to be removed right away, sometimes even before the diagnosis is confirmed by imaging. Remember that this is usually done by inserting a needle or a chest tube in the space between the second and third rib of the affected side on the midclavicular line, which decompresses the chest and provides an escape route for the trapped air. Next, we have pleural effusion, which is excess fluid in the pleural space. This can happen due to either a transudative, exudative, or lymphatic effusion. Okay, so a transudative pleural effusion is when the liquid inside the pleural space is a transudate. It occurs when too much fluid starts to leave the capillaries, either because of increased hydrostatic pressure or decreased oncotic pressure in the blood vessels, usually in the context of conditions like heart failure, cirrhosis, and nephrotic syndrome. You'll be able to differentiate it by the fact that a transudate is low in protein. This can be due to decreased protein production caused by cirrhosis, or because the proteins are lost in urine, like when there's nephrotic syndrome. Transudate also has a low lactate dehydrogenase content, which is a substance released whenever there's tissue damage, and it appears clear most of the time. Next, in exudative pleural effusion, the fluid is an exudate, which is caused by inflammation of the pulmonary capillaries. This allows fluid, immune cells, and large proteins like lactate dehydrogenase to leak out of the capillaries and into the pleural space. In questions, it might appear as a cloudy liquid rich in protein and lactate dehydrogenase. So remember that exudate is associated with lung damage. The causes vary from trauma, malignancy, inflammatory conditions like lupus, or an infection like pneumonia. A rare type of exudative pleural effusion is caused by mesothelioma, and it's called a hemorrhagic pleural effusion. Another rare type of pleural effusion is found in Meg's syndrome, which is a triad of ovarian fibroma, ascites, and pleural effusion. However, its origin is unknown, with some classifying it as a transudate, whereas others stating it as an exudate. Finally, lymphatic pleural effusion, called a chylothorax, is when the thoracic duct is obstructed by tumors or surgery, and lymphatic fluid accumulates in the pleural space. You'll recognize the lymphatic fluid by its milky color and high triglyceride content. Now, the symptoms of pleural effusion depends on its size. A small effusion might go unnoticed, whereas a large one might cause pleuritic chest pain. Another giveaway is that the pain can radiate to the neck and shoulder through the phrenic nerve, and this is called referred pain. Individuals also develop shortness of breath, especially when lying down flat. Classically, on examination, a pleural effusion will cause local signs such as unilateral decreased chest expansion and decreased tactile fremitus on palpation, as well as dullness to percussion, which will help you differentiate it from pneumothorax, along with decreased breath sounds on auscultation. All of these signs are on the affected side and due to excess fluid in the pleural space. Finally, a large pleural effusion can start to compress the chest organs in the same way as a pneumothorax, which leads to a similar clinical picture, like low blood pressure, distended neck veins, tachycardia, and lower extremity edema. Diagnosis can be made by X-ray. In someone standing upright, because the pleural effusion fluid can settle into the costophrenic angle, which is where the diaphragm meets the chest wall, it causes a blurring of the angle as fluid displaces the air that's usually there. On an X-ray taken of someone lying down, gravity will cause the pleural effusion to settle along the chest wall, creating a layering effect. Now it's important to note that in a large or suspicious pleural effusion, the next step would be a diagnostic thoracentesis, which is inserting a hollow needle over the top of a rib to avoid injuring the neurovascular bundle running along the underside of each rib in order to obtain a sample of the effusion. The sample is then analyzed to determine its composition. Next, treatment in larger effusions consists of removing the pleural effusion fluid by therapeutic thoracentesis, both to relieve symptoms and find out the cause. Additional management might be needed to address the underlying cause of the effusion. Okay, so third is hemothorax, which is blood in the pleural space. The condition is usually a consequence of blunt or penetrating trauma to the lungs, and the source of blood may be the chest wall and pleura, lung parenchyma, heart, or great vessels. It could also be iatrogenically induced, like for example by anticoagulant drugs, or by intubation. Usually, what happens is that something causes the pleura to rupture, which means blood will accumulate in the pleural space as it has no way of being drained. Sometimes the bleeding can be so severe that more than a liter of blood accumulates inside the chest cavity, which constitutes a massive hemothorax. Or it can be accompanied by pneumothorax, leading to what is called a hemopneumothorax. Okay, so a small hemothorax usually causes little in terms of symptoms. In a larger one, there might be dyspnea, mostly because the lungs can't expand properly. A large hemothorax could also present with signs of blood loss, like clammy skin, rapid heart rate, and low blood pressure. Just like with pleural effusion, they can have uneven chest wall expansion, decreased tactile fremitus, dullness to percussion, and decreased breath sounds on auscultation. Diagnosis begins with chest X-ray showing findings similar to those of pleural effusion. This is why a diagnostic thoracentesis is needed to confirm the presence of blood in the pleural fluid. Tube thoracostomy drainage is the primary mode of treatment for larger collections of blood, a technique similar to a pneumothorax evacuation. Smaller ones generally require no treatment. Blood usually reabsorbs throughout the course of several weeks. Okay, the last disorder is atelectasis. Although it doesn't directly affect the pleura like the other disorders we've discussed, those disorders can cause atelectasis. In addition, a lot of the symptoms and physical exam findings are similar, so we will go over it in this video. Now, atelectasis is the loss of lung volume secondary to alveolar collapse. It may include a lung subsegment or the entire lung. But unlike pneumothorax, which also caused the lung to collapse, atelectasis is not caused by the leakage of air into the pleural space. Instead, there are many things that can cause atelectasis. Obstructive atelectasis is the most common and results from obstruction of the bronchi between the alveoli and the trachea. This prevents gas from moving into the alveoli, so they collapse. Causes of obstructive atelectasis include foreign objects, tumors, and mucus plugs. Compressive atelectasis is when there's something pressing on the lungs which decreases their volume. Some causes can include large pleural effusions, hemothorax, and tension pneumothorax. Contraction atelectasis is due to scarring of lung parenchyma that distorts the alveoli and impairs elastic recoil, making it impossible for the lungs to fully expand. This is commonly seen in sarcoidosis. And finally, adhesive atelectasis is due to the lack of surfactant, which reduces surface tension at the alveolar air interface and prevents the walls of the alveoli from sticking to each other. Now you might encounter this in questions related to neonatal respiratory distress syndrome, a condition where a newborn's type 2 pneumocytes are not matured enough to secrete surfactant. Adhesive atelectasis can also be associated with lamellar body dysfunction, which are secretory organelles that secrete phospholipids, the main components of surfactant. Now, atelectasis may also develop in individuals undergoing general anesthesia and persist for several weeks. Depression of the respiratory center and decreased activity and coordination of the diaphragm and other respiratory muscles lead to hypoventilation of the dependent parts of the lungs, causing atelectasis. Okay, so the symptoms secondary to this reduction in the lung surface area and impaired gas exchange might include dyspnea, cough, and chest pain. Vitals might show tachypnea and tachycardia. Physical exam findings can be similar to pleural effusion. On the affected side, there's decreased chest wall expansion, decreased tactile fremitus, dullness to percussion, and decreased breath sounds. But crackles can sometimes be heard. Diagnosis is based on chest X-ray or CT scans demonstrating direct and indirect signs of lobar collapse. Direct signs include displacement of the lungs fissures and opacification of the collapsed lobe. Indirect signs include displacement of the hilum, mediastinal shift toward the side of collapse, loss of volume of the affected hemithorax, elevation of the diaphragm on the same side, crowding of the ribs, and compensatory hyperlucency of the remaining lobes, meaning the unaffected lobes will look more black. Treatment depends heavily on the underlying cause. It can include physiotherapy, focusing on deep breathing and encouraging coughing, mechanical ventilation, like continuous positive airway pressure, which delivers pressurized air or oxygen through a nose or face mask to help ensure that the alveoli do not collapse. Alright, as a quick recap, pneumothorax is when there's air in the pleural space, resulting in loss of negative pressure. There are many types, the most serious being tension pneumothorax, which is when there's a flap of tissue creating a one-way valve that traps the air inside the pleural space. Symptoms consist of shortness of breath and pleuritic chest pain, and clinical examination can include decreased tactile fremitus, decreased breath sounds, uneven chest wall expansion, and hyperresonance on percussion. Pleural effusion is when excess fluid collects in the pleural space, and it can be due to transudative and exudative causes, or due to blockage of lymphatic drainage. Symptoms can include pleuritic chest pain and shortness of breath, while clinical examination may reveal decreased tactile fremitus, decreased breath sounds, unilateral decreased chest expansion, and dullness to percussion. Hemothorax is blood in the pleural space. The condition is usually a consequence of blunt or penetrating trauma to the lungs, which causes the pleura to rupture and blood to accumulate into the pleural space. Individuals may develop the same symptoms and findings as pleural effusion, but if there's massive blood loss, They might also have clammy skin, rapid heart rate, low blood pressure. And finally, atelectasis is the loss of lung volume secondary to alveolar collapse. There are several types of atelectasis, usually differentiated by their cause. Signs and symptoms are similar to pleural effusion, but crackles can often be heard on auscultation. Diagnosis of pneumothorax is based on chest X-ray, and treatment consists of chest needle decompression. Diagnosis of pleural effusion begins with chest X-ray and continues with thoracentesis, which can also be used as a treatment method. Diagnosis of hemothorax begins with chest X-ray showing findings similar to those of pleural effusion and is confirmed by thoracentesis. Treatment consists of tube thoracostomy drainage. Finally, diagnosis of atelectasis is based on direct and indirect signs on chest X-ray or CT scans, and treatment focuses on treating the underlying cause. Now back to our cases. George is a young smoker with a family history of pneumothorax, who comes in with left-sided pleuritic chest pain and shortness of breath. On examination, he presented with shallow breathing and a hyperexpanded chest, hyperresonance, with diminished breath sounds. These symptoms, especially the hyperresonance on the affected side, suggests a pneumothorax. His X-ray showed a retracted visceral pleural edge with a reduced lung volume in the lung surface and confirmed the diagnosis. Okay, so Anna has a history of diabetes and cirrhosis and presents with progressively worsening dyspnea and pleuritic chest pain. On physical exam, there was elevated jugular venous pressure, the left lung field is dull to percussion, and absent breath sounds on the left side. These symptoms and physical findings suggest a pleural effusion, likely secondary to her cirrhosis. Chest X-ray showed costophrenic angle blurring, which supports the diagnosis, but a thoracentesis needs to be done to find out the composition of the fluid in the pleura.
Two people are admitted to the emergency department. Mike, a 55-year-old man, presents with shortness of breath, high fever, and cough. A chest X-ray was ordered, and it showed a right lower lobe infiltrate, which is suggestive of pneumonia. He was then started on IV antibiotics, but the following day, Mike became hypoxic and hypotensive. Because his hypotension didn't improve despite intubation, IV fluids, and vasopressors, he is diagnosed with septic shock. Next, a repeat X-ray detected newly developed bilateral alveolar opacities, heart echography ruled out heart failure, and arterial blood gas analysis revealed a PF ratio of 109 milligrams of mercury. Then there was Donna, an infant delivered by cesarean section at 36 weeks gestational age, with an APGAR score of 9 at birth. A few hours after delivery, she develops tachypnea, chest wall retractions with nasal flaring, and tachycardia. Aside from increased work of breathing, her physical examination findings are normal. A chest X-ray was ordered, and it showed diffuse reticulogranular ground glass appearance with air bronchograms. Now, both people are in respiratory distress. But first, a bit of physiology. Normally, when you breathe in, the air reaches the alveoli, which are made up of two types of pneumocytes. First, type 1 pneumocytes are thin and have a large surface area that can facilitate gas exchange. More important for the exams are the type 2 pneumocytes, which are smaller, thicker, and have the ability to proliferate in response to lung injury. They are in charge of making a fluid called surfactant, which contains various phospholipids. This lets it act like droplets of oil that coat the inside of the alveoli, decreasing surface tension, so if it's missing, the alveoli will collapse. These cells also act like stem cells, meaning they can give rise to type 1 cells and type 2 pneumocytes. Okay, So acute respiratory distress syndrome, or ARDS, is characterized by rapid onset of widespread inflammation in the lungs, which can lead to respiratory failure. ARDS is not a primary disease, as it is usually triggered by conditions like sepsis, aspiration, trauma, and pancreatitis. Now, ARDS starts when these conditions cause alveolar damage, and a high yield fact is that the injury triggers the pneumocytes to secrete inflammatory cytokines, like TNF-alpha and interleukin-1. This subsequently leads to neutrophil recruitment, and they will release toxic mediators like reactive oxygen species and proteases, which will damage the lungs even more. You'll need to know that the main site of injury is the alveolar capillary membrane, which becomes more permeable, causing fluid to move into the alveoli, resulting in pulmonary edema. This fluid can impair gas exchange, leading to hypoxemia. Furthermore, the edema can also wash away the surfactant coating of the alveoli to the point where it can't reduce surface tension anymore, and as a result, the alveoli collapse. And finally, dead cells and protein-rich fluids start to pile up in the alveolar space, and over time, it forms this waxy hyaline membrane, which look like a layer of glassy material. Individuals with ARDS present with serious symptoms and signs that require urgent investigation. The inflammation process and impaired gas exchange lead to fever, shortness of breath, tachypnea, chest pain, hypotension, hypoxia, and cyanosis. More often than not, ARDS will lead to shock due to hypotension. The excess fluid in the lungs can cause a crackling sound called rales during auscultation, which is the sound of collapsed alveoli popping open with inspiration. Keep in mind that additional symptoms might provide clues to the underlying cause. For example, epigastric abdominal pain radiating to the back along with a history of gallstones indicate acute pancreatitis. Diagnosis of ARDS is typically made when the individual presents all of the next 4 criteria, which you should definitely remember for your exams. First, the symptoms have to be acute, meaning an onset of 1 week or less. Second, and particularly high yield, a chest X-ray or CT scan shows opacities or whiteout in both lungs, which is due to pulmonary edema. The third is what's called the PF ratio. It's the partial pressure of oxygen in the arterial blood divided by the percent of oxygen in the inspired air, also called the fraction of inspired oxygen. In ARDS, gas exchange is defective, so the PF ratio is below 300 millimeters of mercury, and the lower this ratio gets, the more severe the condition. Fourth, the respiratory distress must not be due to cardiac causes, like heart failure. Often this is assessed by using an echocardiogram to look for evidence of heart failure, like an ejection fraction below 55% in systolic heart failure, and abnormal relaxation of the myocardium in diastolic heart failure. Another clue is the pulmonary capillary wedge pressure, which is measured by inserting a catheter into a small pulmonary arterial branch. In heart failure, this is elevated because more blood remains in the left side of the heart and it prevents pulmonary venous return. The blood backs up into the pulmonary vessels, and the increase in pressure pushes fluid into the interstitium of the lungs, resulting in edema. In ARDS, the pressure is normal since the edema is caused by leaky capillaries instead of increased pressure. Treatment of ARDS ultimately comes down to treating the condition that triggered it. However, the most important initial step is supportive care, like supplemental oxygen or mechanical ventilation. A high-yield fact to remember is that it's vital to maintain positive end expiratory pressure, which is where the pressure in the lungs is kept slightly above atmospheric pressure, even after exhalation, because this prevents the alveoli from collapsing. It's also good to have low tidal volumes to prevent overinflation of the damaged alveoli. Another important thing to watch out for is positive pressure ventilation, which can cause compression of pulmonary vessels, which leads to pulmonary hypertension, decreased pulmonary venous return. This will reduce cardiac output and hypotension might worsen. Now, even with supportive care, the macrophages clean up old cell debris that attract and activate fibroblasts, which are cells that secrete collagen and form scar tissue in the alveolar walls. If there's enough scar tissue, it can still lead to a decrease in lung compliance, or the ability of lungs to expand and come back to their original size. Remember that this means the individual will have residual symptoms all of their lives. Next, neonatal respiratory distress syndrome is a disease of the newborn caused by a deficiency of surfactant. This results in alveoli that can't stay open, and the newborn has to work hard to breathe, resulting in the development of progressive and diffuse atelectasis. Now, there are some risk factors associated with the disease that are commonly tested. First, there's prematurity, usually because the lungs are not mature enough to produce surfactant. Next, maternal diabetes can cause increased insulin levels in the infant, which interferes with surfactant production. C-section delivery is another cause. Normal birth is a very stressful process for the infant, and this increases glucocorticoid levels, which causes the pneumocytes to release more surfactant. During a C-section, there's no boost of glucocorticoids, which can cause a deficiency of surfactant. For symptoms at birth, the newborn might be asymptomatic because they receive oxygen via the umbilical cord before birth. A few hours later, initial clinical signs like dyspnea, tachypnea, tachycardia, and hypoxemia will develop. Eventually, respiratory failure will manifest, and the baby will present with chest wall retractions, expiratory grunting, nasal flaring, or nasal widening while breathing. Eventually, they might become cyanotic. Another fact you need to remember is that since the O2 pressure in the blood will be lower than normal, the ductus arteriosus might not close. A small patent ductus arteriosus, or PDA, might not cause additional symptoms, but a large one might lead to heart failure. Now, you'll be able to diagnose neonatal respiratory distress syndrome by chest radiography or CT, where typical findings include low lung volume and the classic diffuse reticulogranular ground glass appearance. This shows up as a contrast between the black aerated alveoli and the white or gray ones where there's alveolar atelectasis. Another feature is air bronchogram, where the air-filled bronchi appears dark in contrast to the surrounding white or gray atelectatic tissue. Arterial blood gases usually show hypoxemia and hypercapnia. Now, we can also assess lung maturity before the baby is born with amniocentesis, where a sample of amniotic fluid is drawn to measure the lecithin-sphingomyelin ratio in amniotic fluid, both of which are surfactant components. A ratio under 1.5 is predictive of neonatal respiratory distress syndrome. Other tests include the foam stability index and surfactant albumin ratio, which are similar to the lecithin-sphingomyelin ratio test. Regarding treatment, something essential to remember is that antenatal corticosteroid therapy should be administered to all pregnant individuals at 23 to 34 weeks gestation who are at an increased risk of preterm delivery. This is done to prevent or decrease the severity of the syndrome. In newborns without respiratory failure, nasal continuous positive airway pressure is the preferred initial intervention. However, keep in mind that some complications of supplemental oxygen can include retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. If this fails, endotracheal intubation and intratracheal surfactant therapy is needed. All right, as a quick recap, acute respiratory distress syndrome happens when inflammation causes diffuse alveolar injury and pulmonary edema. The 4 criteria of ARDS are: it develops within a week, affects both lungs, causes the PF ratio to dip below 300 millimeters of mercury, and is not due to heart failure or other cardiac causes. Treatment includes supplemental oxygen and mechanical ventilation. Neonatal respiratory distress syndrome is caused by a deficiency of surfactant. Often, this is due to prematurity, maternal diabetes, or delivery through C-section. Diagnosis is based on a clinical picture of the infant with the onset of progressive respiratory failure and chest radiography showing low lung volume, diffuse reticulogranular ground glass appearance, and air bronchogram. Treatment begins with nasal continuous positive airway pressure. If this fails, endotracheal intubation and intratracheal surfactant therapy are needed. Now back to our cases. So Mike presents with acute onset of shortness of breath, high fever, and cough, which together with the chest x-ray showing a right lower lobe infiltrate led to a diagnosis of pneumonia. He was then started on intravenous antibiotics, but his respiratory symptoms only got worse. The next day, Mike developed hypoxemia and septic shock despite appropriate treatment. The x-rays detected newly developed bilateral alveolar opacities. Heart echography ruled out heart failure, and arterial blood gas analysis revealed a severely decreased PF ratio. These 4 factors mean Mike met all the criteria needed for an ARDS diagnosis. Donna was delivered prematurely by C-section, but she initially had a good APGAR score. However, soon after delivery, she developed signs of respiratory distress, tachypnea, and subcostal retractions with nasal flaring and tachycardia. Given her history and risk factors, a diagnosis of neonatal respiratory distress syndrome should be high on the differential list. This was actually confirmed by a chest X-ray showing the classic reticulogranular ground glass appearance with air bronchograms.
While doing your rounds, you meet Josh, an HIV-positive 25-year-old man who presents with a 2-month history of non-productive cough. He also describes poor appetite and significant weight loss, fever, night sweats, and excessive tiredness. He denies dyspnea or hemoptysis. Physical examination is unremarkable. A PPD intradermal test was performed and it was negative. His chest X-ray showed a perihilar lesion with central necrosis and calcification, as well as lymphadenopathy of nearby nodes. Now, this person seems to suffer from tuberculosis, or TB for short. But first, a bit of microbiology. Mycobacteria tuberculosis are slender, rod-shaped, gram-positive bacteria that need oxygen to survive. In other words, they're strict aerobes. One piece of high-yield information is that although they are classified as gram-positive, meaning they have an outer cell wall, it's the same cell wall that makes the bacteria special. This is because Mycobacterium have an unusually waxy cell wall made of mycolic acid, which is composed of long chains of branched lipids, which won't stain with gram. This makes them acid-fast, so the Ziehl-Neelsen stain has to be applied, a dye that will not be washed away by acids, giving the bacteria a bright red color. The wall also makes the bacteria incredibly hardy and allows them to resist weak disinfectants, antibiotics, and allow them to survive on dry surfaces for months at a time. Okay, so tuberculosis is a type of pulmonary infection caused by Mycobacterium tuberculosis, sometimes just called TB bacteria. Before we start, you need to know that there are a few high-yield risk factors for TB. These include immunosuppression, like in people with HIV, iatrogenic immunosuppression, like in people who undergo treatment with corticosteroids, systemic diseases such as COPD, diabetes, and end-stage renal diseases, extremes of age, substance abuse, and populations with an increased risk of exposure, like the prison population, homeless people, those born in an endemic country, and healthcare workers. Okay, so let's start by talking about primary tuberculosis. This is where TB bacteria are transmitted when a person breathes in contaminated aerosolized droplets coughed up by somebody who has TB. This is not normally a problem, as we have plenty of defense mechanisms against the microorganisms we inhale. They are often trapped in the mucus secretions in the upper respiratory tract and coughed up. TB that make it to the alveoli are phagocytized by macrophages, where they are trapped inside phagosomes that later fuse with a hydrolytic enzyme-containing lysosome that normally breaks down harmful microbes. However, TB bacteria can survive this process due to a sulfatide, a surface protein that inhibits the phagosome-lysosome fusion. So, what you need to know is that this allows the mycobacterium to survive, proliferate inside the macrophage, and cause a localized infection within 1 week of exposure. However, most people at this stage are actually asymptomatic and unaware that they are infected because the immune system can contain the bacteria quite efficiently. Now, around 3 weeks after initial infection, a surface glycolipid, called TB cord factor, triggers an immune response where numerous cytokines are released, attracting more macrophages and helper T cells to the area. They try to quarantine the TB bacteria by forming granulomas. Remember that this granuloma formation is a cell-mediated type 4 hypersensitivity reaction, where helper T cells presented with TB antigen activate and release cytokines that attract more macrophages to the area. These macrophages, dead tissue, and bacteria form the center of the granuloma, while helper T cells and multinucleated giant cells, which are formed by the fusion of several macrophages, are found in the periphery. These giant cells, called Langerhans giant cells, are very high yield. Their multiple nuclei are arranged peripherally, resembling the shape of a horseshoe. Their cytoplasm contains Schaumann bodies, which are made of calcium and protein deposits, and abnormal lipid structures called asteroid bodies. Now, in tuberculosis, granulomas are usually caseating. This is because the tissue in the middle of the granuloma dies as a result of a process called caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and resembles cheese. These areas are known as a Ghosn focus. Now, TB can also spread to nearby hilar lymph nodes, either carried over by immune cells through the lymphatic system, or by direct invasion from the Ghosn focus. Together, the Ghosn focus and the affected lymph node form the Ghosn complex, which is characteristic of primary tuberculosis. A high-yield fact is that Ghosn complexes are usually subpleural and occur in the mid and lower lobes of the lungs. From here on, there are a few probable outcomes. In children and immune-compromised individuals, primary tuberculosis cannot be contained by granulomas, so they spread throughout the lungs, causing further damage. This is called progressive primary tuberculosis. In most cases, however, the tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on an X-ray. A calcified Ghosn complex is called a Ranke complex. In some cases, the mycobacteria are killed off by the immune system and the complex heals, leaving just a small scar behind, and that's the end of that. However, if the TB bacteria in the Ghosn complex isn't eliminated, we can get secondary tuberculosis. Even though the bacteria are walled off, they remain viable but latent. If and when a person's immune system becomes compromised, the Ghosn complex can become reactivated, and the infection can spread throughout the lung parenchyma. Another high-yield fact is that the infection usually spreads to either one or both upper lobes of the lung, mostly because oxygenation is greatest in these areas, and TB being an aerobe prefers areas of greater oxygenation. Now, since individuals were previously exposed to the bacteria, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis and more lung parenchyma is destroyed. If the damage is severe, it could cause fibrocaseous cavities. Because the cavities are large, they can allow the bacteria to disseminate or spread through airways and lymphatic channels to other parts of the lung, causing bronchopneumonia. Another way the infection in both secondary and progressive primary tuberculosis can spread is via the vascular system, causing bacteremia. This way, TB can infect almost every other tissue in the body, leading to systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organ affected. Kidneys are commonly affected, resulting in sterile pyuria, or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis, the lumbar vertebrae, causing Pott disease, the adrenal glands, causing Addison's disease, the liver, causing hepatitis, and the cervical lymph nodes, causing lymphadenitis in the neck, also known as scrofula. It can also spread to the joints, where it causes mycobacterial arthritis, and long bones, where it leads to osteomyelitis. Now, the symptoms of pulmonary tuberculosis are varied, depending on the phase of the disease and any comorbidities. Primary tuberculosis might be completely asymptomatic, or it might present with classic findings, including fever, night sweats, weight loss, non-productive and productive cough, and hemoptysis, usually secondary to the infection eroding the pulmonary blood vessels. Secondary tuberculosis will have similar symptoms, and miliary tuberculosis might cause additional symptoms depending on which organs are affected. Screening for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, Mantoux test, or simply TB test. With this test, tuberculin, a component of the bacteria, is injected between the layers of the dermis. If a person has previously been exposed to TB, the immune system reacts to tuberculin and produces a small, localized type 4 hypersensitivity reaction within 48 to 72 hours. If the reaction creates a large enough area of induration rather than just redness, the test is positive. However, a positive tuberculin test simply means the individual has been exposed to the TB bacteria at some point. It doesn't differentiate between active, latent, or resolved infections, hence why it's a screening test and not diagnostic. PPD is negative when there's no history of infection. There's also the chance of false positive results in those who are vaccinated against TB, and of false negative results when the immune system is too impaired to even react to tuberculin, like in individuals with AIDS. Sarcoidosis can also lead to false negative results because the affected individuals have impaired delayed type immune reactions. As an alternative screening test, there are also interferon gamma release assays, or IGRAs. Basically, they work by measuring the amount of interferon gamma released by T lymphocytes when exposed to antigens unique to Mycobacterium tuberculosis. IGRAs are more specific to TB rather than other types of mycobacterial infections, and are less likely to give a false positive result. If any of the two tests were positive and the individual presents characteristic symptoms, the next step is a chest X-ray to look for signs of active TB disease. Gone complex with calcification is a classic sign of TB, but cavitation and scarring in the upper lobes are more suggestive of secondary TB. Miliary tuberculosis, on the other hand, can cause numerous small nodules that are uniform in size and distributed throughout the lungs. In fact, miliary refers to the millet seeds that these nodules resemble. If chest radiography was positive, it's important to collect 3 samples of sputum at least 8 hours apart and including at least 1 early morning specimen, or alternatively, by bronchoalveolar lavage. These samples are sent to the lab for staining, culture on Lowenstein-Jensen agar, and nucleic acid amplification test to look for evidence of Mycobacterium tuberculosis. A biopsy of the nodule might also be beneficial, which can reveal caseating granulomas with central necrosis and Langerhans giant cells. Now let's look at treatment. For latent TB infection, it typically involves using monotherapy with rifamycin for 4 months. This is now preferred over monotherapy with isoniazid for 9 months, which used to be the #1 option. Monotherapy with isoniazid for 9 months is still, though, the only regimen used as a prophylaxis against TB in those at risk of developing the disease, especially in individuals with HIV. Treatment of active TB disease is typically done through a combination of anti-TB antibiotics called the RIPE regimen, which consists of rifampin, isoniazid, pyrazinamide, and ethambutol. Streptomycin can also be added to the initial regimen if necessary. Otherwise, it's considered a second-line solo agent. There are a few other things you need to know for your exams about these antibiotics. First, rifampin works by blocking the bacteria from synthesizing DNA-dependent RNA, thereby preventing transcription. With no way of generating mRNA, the bacteria will die. This mechanism allows it to work on a wide range of bacteria, not just TB. The only downside being that if the bacteria develops a mutation that changes the enzyme responsible for DNA-dependent RNA synthesis, it will develop bacterial resistance to rifampin. Some side effects include minor hepatotoxicity and drug interactions, and, something less serious, orange body fluids. Second, isoniazid acts by inhibiting mycolic acid synthesis, meaning it only works on TB. However, isoniazid needs to be processed by the mycobacterial catalase peroxidase to be activated. So, if TB develops a mutated gene that results in the non-expression of the catalase peroxidase enzyme, or if it acquires a mutation that modifies the isoniazid binding site on the mycolic acid synthesis enzyme, the bacteria can develop resistance against isoniazid. Some of its side effects include hepatotoxicity, P450 inhibition, drug-induced lupus, anion gap metabolic acidosis, and seizures that are refractory to benzodiazepines. Now, it can also cause vitamin B6 deficiency, which can lead to peripheral neuropathy and sideroblastic anemia. This is why isoniazid is administered at the same time with pyridoxine, which is a B6 vitamin. Third, pyrazinamide has an unknown mechanism, but it works best at relatively acidic pHs, as within phagolysosomes, which is why it is the most efficient against the TB engulfed by macrophages. Pyrazinamide can also cause hyperuricemia and hepatotoxicity. Fourth, ethambutol inhibits arabinosyl transferase, an enzyme that polymerases a part of the bacterial cell wall. Without this enzyme to promote carbohydrate polymerization, TB dies since it can't build its cell wall. Ethambutol doesn't work on other microorganisms, but it can be used to treat atypical mycobacterial infections. It also requires periodic visual acuity testing, as it can lead to optic neuritis, which is inflammation that damages the optic nerve. Optic neuritis leads to symptoms like decreased visual acuity, color blindness, and blind spots, all of which are reversible if the drug is stopped. And finally, streptomycin is part of the aminoglycoside family, and it works by inhibiting the bacteria's 30S ribosomal component, ultimately preventing bacterial protein synthesis. Obviously, mutations to these bacterial ribosomal proteins cause streptomycin resistance, which is actually quite common since this agent was one of the first antibiotics to treat tuberculosis effectively. Additionally, there's an enormous concern about new drug-resistant strains of TB that are causing infections in various parts of the world. You may hear of MDR-TB, or multi-drug-resistant TB, or XDR-TB, which is extremely drug-resistant TB, both of which are incredibly hard to treat because they don't respond to treatment with the usual antibiotics. Recently, the U.S. Food and Drug Administration has approved a breakthrough medication for XDR-TB, called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. Alright, as a quick recap, tuberculosis is an infection caused by Mycobacterium tuberculosis that mainly affects the lungs. Primary TB is when lung infection occurs after inhaling contaminated respiratory droplets. The immune system tries to contain the infection by creating granulomas, and the tissue in the center can undergo caseous necrosis, resulting in Ghosn focus. TB also extends to nearby hilar lymph nodes, and together with Ghosn's focus, they form Ghosn complexes. If the immune system becomes compromised, like with AIDS or older age, Ghosn foci can reactivate, and the infection can spread to one or both upper lobes of the lungs, where it forms cavities. From these, bacteria can disseminate to other parts of the lungs, causing bronchopneumonia. But it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB starts with a PPD intradermal skin test, or with an IgRA blood test. And a chest X-ray can identify signs of active TB disease. In individuals with fever, night sweats, weight loss, and hemoptysis, a sputum sample can be used to identify Mycobacterium tuberculosis. Treatment of active TB includes a combination of antibiotics called the RIPE regimen. And now back to our case. Josh is a textbook case of tuberculosis. His history of HIV infection is a risk factor, and he presents with non-productive cough, significant weight loss, fever, and night sweats. The screening via the PPD intradermal test was negative, but this might be due to a diminished response due to HIV. His chest X-ray showed a gum complex though, so the next step would be to start him on RIPE.